Hello, Esa. Nice to see you back again. All right, we'll start off with the first case. We have total of 8 cases and 2 follow-up cases. I think pretty interesting, complex cases this Friday. Without further ado, I'll start off with the first case, and if Apurva is there, over to her.
Yes, sir. So this is a 6-month-old male child who came with complaints of fever for 2 days, associated with irritability, reduced oral intake, and increased sleepiness. On day 2 of illness, the child had one episode of generalized tonic-clonic seizure, for which the child was admitted in local hospital. There, the child had multiple episodes of tonic posturing and persisting encephalopathy, for which the child was referred to our hospital. On examination, the child was stuporous, and the GCS was E1, V2, and M3, and there was spasticity of gastric nemes with dystonias. So, based on these findings, we suspected acute febrile encephalopathy, and the child underwent an MRI.
All right. Okay, the MRI, we have the diffusion and ADC sequences. And on the diffusion-weighted sequences, you can appreciate confluent areas of restricted diffusion, predominantly involving the cortical regions of the bilateral cerebral hemispheres, also some areas of patchy involvement in the bilateral basal ganglia. In terms of the infratemporal regions, the brainstem and the cerebellum did not demonstrate any changes on diffusion-weighted sequences. On the T2-weighted sequences, you have more additional abnormalities which had some degree of facilitated diffusion, more involving the deep white matter, the periventricular white matter, more extensive involvement of the basal ganglia, the internal capsule, and also brainstem involvement is not there on the diffusion. So brainstem abnormalities, slightly asymmetrical, patchy abnormalities involving the brainstem more on the left side. On the SAT sequences, you can appreciate the involvement of the brainstem, especially the upper aspect, that is the midbrain, the pons, and also the corpus callosum. This is a post-contrast flare on top, and I could not appreciate any significant enhancement on these the post-contrast images. On the SWS sequence, there was a punctate foci in the right occipital lobe. Other than that, no other abnormalities on the GRE SWS sequences. Optic nerves, mild optic neuritis on both sides. So this was the only finding on the contrast sequences. Spectroscopy was done, demonstrated a mildly elevated choline peak, given that the child is 6 months and still myelinating. There was a mildly inverted lactate peak, but the choline to Na ratios, given that this is still an infant child with still undergoing myelination, was relatively okay. Nothing suggestive of a neoplastic lesion, more suggestive of an inflammatory etiology. Based on the imaging findings, we thought of possibility of infectious, para-infectious etiologies in the para-infectious spectrum, thinking of MOG, particularly looking at the diffusion sequences, thinking of MOG-related encephalitis, the fulminant variants, which can present in the early age group and can have these symmetrical or asymmetrical confluent abnormalities. So para-infectious was one of the differentials. HLH, I thought we have a companion case, but possibly one of the differentials, if you see the diffusion pictures, can be similar to what we see in some cases of HLH. The other common one was the infective etiology. In infections, viral etiologies were most, kept in the as a possibility in comparison to the other infective processes. And then I think the labs were done, Pura.
Yes, sir. So after that,
Just a
CBP was
question,
done,
Nihaal.
which was
Sorry, yeah, sorry.
Apurva, just no. On the images, whether
Yeah.
there was a slight difference in the timing of like basal ganglia restricted diffusion versus the other changes. We were thinking whether it's this two-stage kind of lesion.
No, it's a mixed pattern, which we commonly see in these para-infectious etiologies. The mixed pattern can be seen in mitochondrial disorders, but they should be more symmetrical, more confluent. Over here, it is slightly asymmetrical, as you have seen, especially the brainstem, the basal ganglia, and the white matter structure. So the mixed pattern it can be seen in para-infectious at the same time.
Okay, sure. Yeah, so that was one thing. On the extensive restricted diffusion, the age of the child were the things which were actually driving us towards a infective or sort of a least kind of pathology initially clinical. Yeah, good. Good.
Yes, but labs were done in which CBP was 11, TLC, there was a mild elevation 15,000, but neutrophils were 59%. We did CSF analysis, which was completely acellular. Protein was 29 and glucose was 60. We sent a CSF comprehensive panel that include bacterial, viral, and fungal panel, which was negative. EEG, there was diffuse flowing but no interictal discharges. In view of suspected mitochondrial pathology based on the MRI changes, we did serum lactate levels, which was also normal. And because of that fluffy involvement, we sent serum MOG, and which was strongly positive. The child was started on injection methylprednisolone, and within 2 days of methylprednisolone, there was drastic improvement in sensorium. There was good eye opening. There was fixing and tracking, hence correlating with the pathology.
Okay, so we have a strongly positive MOG. Spine wasn't done, Isa. So I'll just open the case. If anyone has similar cases in such a early age group with such a severe pattern of MOG-related disorders.
I think it reminds me of a case presented by Anaisa and team, which was a 4-month-old child, extensive thalamic changes, which worsened in second MRI. And we were thinking that's just an aberration. But I think as we are seeing this child as well, probably we need to test no age is immune to develop MOGAD. I think we need to have routine testing in all encephalitis. I think that's what many of the centers around the world are getting into. All encephalitis, they are doing autoimmune panel, NMDA, MOG panel, MOG and NMDA as part of the evaluation apart from the viral encephalitis.
So I have Hiren here who had presented the case to Dr. Anantha. Hiren, any comments? What was the age group of your child? I think 4 months, no?
Yeah, exactly. Like it was 4 months old child, and initially we were not thinking of MOG as a this thing. And initially the lesions were there in the bilateral basal ganglia as well as in the brainstem involving the midbrain. But later on follow-up, we also were seeing further increase in size of the lesions as well as new areas of abnormality in the periventricular white matter, which was reaching up to the subcortical and depth of the cortex, especially in left-sided parieto-occipital region. So at that time, we thought that, okay, we should investigate for MOG also, since viral panel was negative and then MOG came out to be positive.
And it was 4 months old.
Yeah, it was 4 months old, yeah.
Okay.
I think we can have a cohort of less than 1 year old.
Less than, infantile MOGs,
look at that. Yeah. Okay. Thank you.
All right. Thank you.
Yep.
All right. Harika, if you're there, over to you.
It's it. This is 13 years old male child with the complaints of difficulty in walking and swaying to right side for 3 days. And at the time of presentation, child had complaints of right hemisensory numbness for 3 days. And child had also double vision on looking to the left with deviation of MOG to right for 2 days. On examination, left 6th and 7th nerve, lower motor nerve weakness was there in the form of restriction of left eye abduction and deviation of angle of MOG to right. And on sensory examination, there was decreased pain and temperature sensation, proprioception and fine touch on the right side. And tandem walking was impaired. Rhomboxine was positive.
All right. Imaging, I think, was done 7 to 8 days after the...
Harika, can you try and clinically localize this?
Yeah.
And what are these syndromes called?
Yes, sir. With the involvement of 6th and 7th nerve, it localized to pontomedullary junction, and also there is difficulty in walking and swaying to right side. It also indicates cerebellar involvement in the form of pontocerebellar tracts and decreased sensations that can be due to involvement of medial lemniscus in the pons.
All right.
Okay. Sure.
Yeah. So imaging was done, I think, 7 to 8 days after the presentation. And this is the images. I think the main findings are restricted towards the posterior fossa in the brainstem. On top is the T2 axial sequences, and you can appreciate T2 heterogeneous hyperintensities involving the brainstem, predominantly the pontine structures, as mentioned by Harika. The localization is in the pontomedullary junction. if it appreciated on the sagittal sequences out here. So there is extension of involvement from the midbrain to the medulla with predominant involvement of the pons. Some cystic areas or slightly hyperintense areas demonstrated within the pons on the left side. On the flare sequences, again, you have similar abnormalities, the edematous abnormalities predominantly involving the pons and the pontomedullary junction. Diffusion did not demonstrate any abnormality. SWI, I think, let me see. I don't think I have the SWI, but post contrast to sequences out here, you have these punctate areas of enhancement, some incomplete curvilinear areas of enhancement, especially in the pontine abnormality. And on the spectroscopy, could not appreciate any significant peaks. The slightly inverted lactate peak out here, but other than that, nothing very significant. Spine was screened. We don't have axial sequences. I think these are likely motion related changes on the spinal cord and the side sequences, though axials would have been helpful. So the predominant changes are in the brainstem structures and in the pons. Based on that, we looked at the pontine lesions, which can present with similar imaging patterns. Brainstem encephalitis can have these similar imaging patterns. The ADEM or any variants, which usually is not isolated, but sometimes can demonstrate similar imaging appearances. Given that the incomplete ring enhancement, possibly evolution of TB related change, other abnormalities can present and affect the brainstem are listeria. Fungal abscesses can also be present. Less likely would be the LCH and the gliomas based on the imaging. Vasculitis can also have some degree of enhancement as seen in our case, and brainstem involvement. Then the question from the, I think, neurology team was, can this be clippers or non-clippers? So clippers, these are the typical imaging findings. They have these punctate abnormalities along the perivascular spaces. So this is what we are seeing over here. And the non-clippers, which was identified in the same paper, you have these multifocal abnormalities, more nodular enhancement, more mass-like lesions. So if they are asymmetric in nature, there is more extensive involvement of T2 signals beyond the contrast enhancing areas. There is mass effect and there is lack of resolution on the following steroids. One must think of the non-clippers like lesions, I think, which corroborates with our case. So thinking of inflammatory infective etiologies as the primary possibilities. And based on that, I think we got the labs done. Harika?
Yes. Complete blood pressure of 12.9 because elevated WBC count of 14,000 with the neutrophilic predominance and platelets being normal. And we have done CSF analysis, which was acellular and glucose being normal and proteins 22 milligram percentage. And we have sent CSF comprehensive panel that caused bacterial, viral, and fungal and TB PCR, which was negative. This also covers listeria. Serum mumps, IgM and IgG was sent as child had doubtful history of mumps 1.5 months ago, which was negative. And we have sent capsid antigen for EBV IgM that was non-reactive and IgG was reactive. And serum NMO was sent, which was negative.
Okay, so we don't have a clear, yeah, sorry.
Now the question is, we don't have a clear answer for the etiology.
Yeah.
Child had some partial response, like maybe 50 to 70% response after the 3 doses of steroids. So after that, because we did not have any clear answer, we were awaiting MOG. On follow-up, his symptoms he had response for 3 days, and then he had recurrence of symptoms. So now we were at this juncture. So is it like a infective or para-infectious? There's no worsening as such, but it's back to the condition which he was prior to the administration of steroid.
Okay, and that wouldn't, the timeline is not for recurrence. It's too early for recurrence.
Just maybe 3 days, 3 days gap, 3 days gap.
Yeah.
It's exactly the same symptoms which has come back to the baseline level after improvement, as Anna said. So it is something which is not fully responsive to steroids. So we gave another 2 dosage, total 5 doses of steroids, and wanted to discuss in the meeting before doing anything further.
All right, case is open. Any further comments?
Nihaal, can I comment something?
Yes,
So,
go ahead.
Yeah, so we had similar case in Mumbai. So, and we had follow-up images of that patient. We were following up for 4 or 5 years. Initially presented with similar brainstem lesion, which was like almost like this what you are showing here as a mass-like appearance and some sort of central, this bright hyperintense fluid signaling area. So we also were initially in dilemma that what is this? Is this some sort of clippers versus demyelination versus some early malignancy or something? But then after, again, the patient had a recurrent history of what you are telling, that recurrent history of encephalitis and those kind of symptoms. And subsequently on second or third scan, what we found that the patient had new lesions in the supratentorial location, which are periventricular ovoid shape. And every time we scanned, we were seeing that this lesion, which was there initially in the brainstem, was resolved, but there were a few lesions which are cortical, juxtacortical in periventricular location, and those kind of which are typical for multiple sclerosis. So we investigated further after fourth or fifth follow-up that patient for the MS workup and all. So at that time, some oligoclonal bands were positive. So then we concluded that this might be a case of multiple sclerosis. So the point I'm trying to say that this might be a case of demyelination, may not be MS, but some sort of acquired demyelination. That is one of the strong possibility, especially if the patient is responding to the steroid. Maybe follow-up will tell you the answer.
Okay. Thanks, Reddy.
Thank you.
Yeah.
Thank
Yeah.
you for sharing that.
Yeah, so I think we are going with parainfectious process and a follow-up MRI, maybe 4 to 6 weeks time. Or if the child is recovering, then it's fine. But if there is deterioration, then earlier, I guess. What is the timeline for steroids, Dr. Lokesh? 2 weeks? How long do we get steroids?
No, pulse we have completed.
Okay.
The day before yesterday was the last dose of pulse. We
Okay.
are going to start oral after tomorrow. Yeah. Tomorrow.
Okay. Okay. So after I think one course, we can get a scanning.
Yeah, 6 weeks at least the minimum.
Yeah,
So that.
yeah. Sure. Okay. Anything on the chat? Okay. Demyelination anti-IgG4. All right. No X-ray. Melioidosis, listeria. So listeria was negative on the serology. Okay. Yeah. So we'll get back to you with a follow-up in about 6 weeks' time. Okay, say Dr. Ankush, if you're there. Dr. Ankush, I think you need to unmute.
Hello, can you hear me?
Yeah, please go.
So this is a 2.5-year-old boy, clinically developmentally normal child. He presented with recurrent episodes of unprovoked seizures. So clinically he behaved like epilepsy. So the seizures were predominantly left focal seizures. Otherwise, no. Otherwise, no other. All other clinical details are normal.
Okay, but going on for the past 1 year.
Hanji?
Wait, going on for the past 1 year, since 1 year. So seizures are there
for last
seizures?
No. Seizures are. He's on a single anti-epileptic, so the dosage is being increased. Okay. He had 4 seizures in last 1 year.
Okay.
The seizures began at the age of 1.5 years.
Got it. Okay. So I have flare and T2 axial sequences, and you can appreciate the abnormality, especially in the right temporal occipital lobe. Over here, you can see that there is T2 and flare hyperintense changes involving the temporal lobe, predominantly the temporal lobe extending into the occipital lobe, the periventricular white matter out there. Some degree of, I think, chronic changes in the bilateral posterior periventricular regions with some squaring out there, patchy abnormality out here in the right frontal lobe. But the predominant changes are in the right temporal lobe. On the GRE sequences, we could appreciate multiple foci of blooming on the GRE sequences, again involving the temporal occipital lobes, predominantly the subcortical cortical region. CT scan was done on the same day, which demonstrated calcific foci, especially along the gyri and the subcortical regions in the temporal lobe, and also in the paramedian occipital lobe out there. Post-contrast study, I could not appreciate significant enhancement in the temporal lobe abnormality. There's possibly some degree of left-meningeal enhancement over here in comparison to the contralateral temporal lobe. Better appreciate on this image. But yeah, intraventricularly, I could not appreciate any abnormality. Some left-meningeal enhancement in the temporal occipital lobe. and no enhancement in the temporal lobe abnormality. Angiography was done. Again, could not appreciate any significant findings on the angio. So the question arises, as you have seen in the chat, Dr. Ankush, any neurocutaneous markers for a possible Sturge-Weber syndrome?
I mean, when the child came, I saw the child only once in my OPD. I mean, there is no lesion on the face, but the mother is saying that red-colored lesion appears on the right side of the face, but it was not present on the day the child presented to me. So she says that it appears sometimes and then it disappears. So I have asked them to do an ophthal evaluation to look for increased intraocular pressure. There was the right eye was hyperemic. I mean, the vessels were inflamed on the right eye.
Yep.
So I mean, radiologically, is it Sturge-Weber?
The only question is, I'm not sure of these abnormalities in Sturge-Weber. At least the temporal lobe abnormalities. I've not seen them. If anyone has any experience, was a spectroscopy done by any chance, Dr. Ankush?
No, spectroscopy was not done.
Okay.
Only MRI, contrast MRI and CT was done.
Yeah, and the diffusion was not restricted, just in case I've not put in the images, but there are thoughts of HSV encephalitis.
HSV encephalitis. I mean, clinically, he's just behaving like epilepsy.
The white matter change. Yeah, the edematous changes. Sorry. Yeah, go ahead.
I mean, clinically, he's just presenting with left focal epilepsy.
Okay.
I mean, the neurocutaneous marker, it should not disappear now. I mean, when the child came to me, the face was normal. I mean, there were no skin lesions anywhere on the body.
Yeah. These abnormalities are not typical of Sturge-Weber, at least not the common ones which we know of. The edematous changes. And even the SWA does not corroborate with the calcification. If you see, this is more in the white matter periventricular region, and the calcification is more in the cortex. So these are some microhemorrhagic foci. Possibility of vasculitis, I'm not sure. I don't think to be considered.
I think was it close to the seizure that might give rise to some edema? Is that possible?
You mean the scan, Dr. Lokesh, timeline?
Yeah, in the scan. Yeah, scan. How close was it to the seizure, and whether that can give rise to a little bit of edema on the chronic lesion?
Seizure. No, but I mean, Dr. Lokesh, there are on the CT there is calcification, no? So.
No, he's asking that the seizures were it in the acute phase. We have scanned the patient, which.
Yes. The last MRI was done maybe one day after the seizure.
Okay, yeah. So a chronic lesion, something like Sturge-Weber mimics those group of disorders where you can have absence of facial angiomas, leptomeningeal angiomatosis. So where you don't use the word Sturge-Weber, so leptomeningeal angiomatosis. But only a odd point is they usually have more of parietal and occipital, but we need to search whether the temporal lobes are also involved in this sort of situation. But rest of the things fit into some form of leptomeningeal angiomatosis, I think. Does that qualify for leptomeningeal angiomatosis?
The calcification and the contrast, yes.
Contrast findings, yeah.
But the only odd points are these hemorrhagic foci.
And Dr. Lokesh, should I give aspirin in this patient?
I think if there is leptomeningeal angiomatosis, very frequent seizures, I think it's worthwhile, especially get an eye evaluation and then.
I have asked them to get an eye evaluation. I've asked them to get it done.
Yeah, it's a good thing to look at. Yeah.
Thank you, Dr.
Ankush, my only concern is maybe a little uncommon, but we should not be missing a glioma or a glioneural tumor.
Okay.
So that's why I asked for a spectroscopy, and even though the child has 4 episodes of seizures.
Okay.
The low-grade gliomas can also look like this. I mean, or the glioneural tumors.
So you want me to do an MR spectroscopy, no?
Yeah,
Okay,
maybe that would be helpful, I think. Yeah.
Okay, then they'll come back. I'll ask them to get. I'll get an MR spectroscopy and I'll send the films to you.
Yeah, eye examination with intraocular pressure.
Yeah.
Yes. They will get. They'll come back to me with the intraocular pressure done.
Yeah.
Okay. Thank you.
There's a comment of antiplatelet medication by ISA to be given to Sturge-Weber syndrome. Anti-platelet administrations. Medication, sorry.
Yes, so I was reviewing the literature. They said that because Sturge, it can cause chronic ischemia. So
yeah,
there might be some, indication for aspirin.
Yeah, aspirin and sirolimus. Sirolimus actually is very helpful to prevent stroke-like episodes. Nothing works like sirolimus in the Sturge-Weber. So we use it quite regularly in extensive Sturge-Weber syndrome, sirolimus for 1 to 2 years to prevent the stroke-like episodes.
Okay, Dr. Lokesh. Thank you.
Yeah. Some further comments. Vasculitis from Dr. Kanika, cortical calcifications due to venous ischemia from Manoj. So yeah, I think the ocular examination with a spectroscopy and a follow-up would be helpful, I think, Dr. Ankush.
Okay.
Yeah.
Thank you, Dr. Nath. Thank you.
Thank you.
I'll get it done. Huh?
Just because the child is having multiple seizures, I just wanted to roll it out before it's fully blown up.
Okay.
Yeah.
Okay. I'll get it done.
Thanks. All right. Dr. Sayoni, are you there? Okay. I can't find her, so we'll probably skip the case and maybe hope that she joins in later. All right. Over to Dr. Kanika and Dr. Rajni.
Dr. Rajni, are you there? Yeah. Dr. Rajni, are you there?
Just check.
Okay, it's a 7-month-old child. First of the twin delivery with spontaneous conception and uneventful delivery. Patient presented with global developmental delay, epilepsy, and progressive deterioration. The seizures were around 2.5 months, which were generalized tonic and with vacant stare. Later, they evolved to tonic choking episodes for which the patient was ventilated. An MRI was done at 3 months of age, which was normal. We don't have the films. So you
want me to? Yeah. Okay, Kanika, do you want to describe the findings? Yeah.
So these are the T2 axial images. There are signal change in bilateral caudate nuclei, putamina, and they're also extending into the globus pallidi. There's mild prominence of extraaxial CSF spaces in frontal regions. Rest of the cerebral parenchyma appears normal. The posterior fossa is also normal. On DWI, these are diffusion-weighted images. There are areas of restricted diffusion, again in the new striatum, which are also extending into the globus pallidi. And there is also subtle signal chain restricted diffusion in the superior part of the thalami bilaterally. And these are hypointense on the ADC maps. So these are all acute lesions. And gradient sequence did not reveal any hemorrhage in these lesions. So these are the ADC maps. These are showing restricted diffusion. The same areas, bilateral, caudate nuclei, putamina, extending into the globus pallidi as well. Then the T1 weighted images show normal myelination for patient's age. So, and then we also did MR spectroscopy at intermediate TE, and that showed a inverted lactate peak. So based on, so based on the imaging features, a possibility of biotin thiamine responsive basal ganglia disease and a mitochondrial disease like LAYS were considered. since there's no widening of the Sylvian fissure, glutaric aciduria was ruled out, and the clinical did not fit into any infectious pathology. So patient was put on high dose of biotin thiamine along with a mitochondrial cocktail was given, but the encephalopathy continued with life-threatening episodes, but the child's blood lactate were controlled and the child was tracheostomized and managed symptomatically. And then we have a follow-up MRI was done. So this is just a screening MRI we did. The areas which were showing restricted diffusion, they show now gliosis. There's gliosis in bilateral caudate nuclei, in the putamen, and also extending into the globus pallidi. There's no gliosis seen in the thalami. Rest of the brain is fine. Then we have the FLAIR images. These are mildly hyperintense areas on the FLAIR images. In the areas of gliosis, no restricted diffusion. So within 2 weeks, gliosis developed in bilateral basal ganglia as well as. So a genetic test was done, and this turned out to be a PDH, pyruvate dehydrogenase deficiency disease. And so thiamine was continued and the child was started on ketogenic diet.
All right. Thank you, Kanika. And just to highlight the main features of the PDH1 mutation, as you know, on the CNS neuroimaging, the Leigh syndrome type variant is the common imaging manifestation. I think clinical pulse, it can present with only metabolic prominent phenotype, that is with severe lactic acidosis, or a neurological prominent phenotype with hypotonia, Leigh disease, dystonia involving the basal ganglia structures. And as outlined, the therapy involves the thiamine and ketogenic diet, which the child is on. So I'll open the case if anyone has similar imaging findings or any clinical prognosticating factors for this child. I think in the chat, Isa has already, as mentioned, the Leigh disease, one of the possibilities was considered Leigh, and diagnosis is right. Ketogenic therapy is efficient, question mark, Isa. To any of the neurologists who want to take it up, is ketogenic therapy efficient for mitochondrial disorders and especially PDH-related disorders?
It is suggested, but pyruvate carboxylase, I think it worsens, whereas in this, there might be some benefit, but ultimately they are all slowly progressive illnesses most of the time and get into respiratory failures. So it's generally a fatal disease. They can have intrauterine onset of problems. Some of these children can be born with significant hypoplasia of corpus callosum and intrauterine onset of basal ganglia lesions as well. So that presentation is also known with respiratory failures.
Yeah, but this patient had normal corpus callosum for the age of
Some of them with a more severe deficiency can have an intrauterine onset.
So the intrauterine ones usually have some malformations too. Dr. Location mentioned corpus callosum, basal ganglia, subependymal cyst, dysplastic lateral ventricles, globus pallidus abnormalities, more in the antenatal perinatal variants. But this is one more of a later onset, which has these typical basal ganglia Leigh type features. Question is highly efficient ketone body treatment in glutaric aciduria. Glutaric aciduria, yes. All right. The question is, if ketone body treatment was started, would the gliosis be prevented? But this is not glutaric aciduria. I thought this is the case of
you don't give. I don't give ketogenic diet. It is a low there is a different diet where you use sort of supplements which are known to reduce the substrate levels.
I think the case she's asking for this case. I think anyway there would be some progression of gliosis eventually. Isn't that right, Dr. Lokesh? Even if we give thiamine or ketamine.
It worsens. It worsens. It worsens. It progressively worsens.
Okay. All right. Thank you. All right, thank you, Kanika, for your case. So that's the case of PDHA1 related disorder presenting with a Ley-like syndrome. Thank you. We'll move back to Rainbow if Anas is there.
Sir. Yeah. So I'll present. Yeah.
Yeah, Anas, go ahead.
Yeah, sure. It's a 5-year-old child presented with history of fever for 10 days, headache with vomiting for 10 days, not also any photophobia or phonophobia. So she came to us on 10th day. On examination, pupils were normal, normal cells reacting to light. No RAPD, fundi was normal, no neck stiffness, meningeal signs were absent as well. So in view of this persistent headache and fever, we went ahead with the MRI.
All right, MRI, I have only the clear axial sequences, no parenchymal abnormalities or significant abnormalities. The punctate foci out there, non-specific in nature, but no other areas of focal abnormalities, no signal changes on the flare sequences, supratentorial, infratentorial, no signal changes. On the SAT sequence, you can appreciate the normal structures of the corpusculus on the brainstem and the cerebellum, possibly some mild degree of volume loss in the anterior vermis and the cortical regions of the supratentorial brain. But other than that, no focal lesions appreciated in the supra and infratemporal brain. The main finding here was the optic nerves, diffusion various sequences. We have some area of diffusion in the bilateral optic nerve. Post contrast, there is some degree of perineuritis involving the bilateral optic nerves, the long segment involvement. On the coronal sequence, also you can appreciate these areas of perineuritis. I just put out the head and neck section out there because the follow-up diagnosis might be related to it, but no significant abnormalities in these areas out here. So the patient was evaluated and Anastia.
We did initial blood. So CBP was normal, mild WBC was elevation. Seen CRP was normal, electrolytes were normal. We had some CSF to rule out meningoencephalitis. Protein sugars were normal. Opening pressure was done. It was 28 centimeter water was elevated. Cells were 81, all lymphocytes. We had some PCR, panfungal, bacterial, fungal, and viral. Was negative. She did not have history of mumps actually, but we because we are seeing this lots of cases of mumps, we had sent it, which came positive. Serum NMO MOG was also sent, which is awaited. VEP was 108 in both right and left side. So the main question here was, not question as such. A typical feature here was there's no history of mumps, but no meningeal signs, no clinical optic neuritis, but the features of all the three. So we're wondering if is this reported phenomenon.
Okay, the question is it primarily mumps-related optic neuritis? I could find, I think, 2 case reports demonstrating only optic nerve involvement in mumps. Some also had pyotitis, but our case did not have any pyotic gland inflammation. The other common pediatric optic neuritis-related conditions are the other viral infections and the inflammatory demyelinating conditions such as MOG and NMO. So the question is, would you consider this as a primary mumps-related optic neuritis, or would you still test it for parainfectious etiology?
No, I think we would test it definitely. But if that comes negative, is it good enough proof to say this is probably related to mumps is the question, because you're in a almost like a epidemic situation of mumps causing lots of infections. And many children, whether related or unrelated, like in COVID situation, we used to have antibodies, whether related or unrelated, we had to prove it by ruling out other conditions. So we've sufficiently ruled out other conditions with this finding. So whether we can still say it's mumps, because the treatment implications are different.
So anyone has any experience with mumps and optic neuritis? So as a quick comment, in the absence of pyotic swelling or salivary gland involvement may present with symptoms of visceral and CNS-related mumps. Grishma, I think from Amrita says, yes, retrobarbar neuritis seen in mumps. ISA again has complication of mumps-related infection with optic nerve involvement. Yes. So Grishma, was this only isolated optic nerve involvement, or there were other changes of mumps in the brain? Yeah, pyotitis. Yes, I remember the case. The child had pyotitis, but our child at this point did not have pyotitis. That is from RT.
Yeah, there are some children. Yeah, there are some children without pyotitis who can have mumps. Yeah.
Okay. So yeah, so I think the Kochi group has some experience with optic nerve changes with pumps. So we'll await the MOG and NMO results, and I think if that is negative, maybe attributed to mumps. Is that right, Dr. Lokesh? Sorry, chemistry random. Sorry, I think, yeah.
Yeah, Dr. Kalpana madam was with last time.
Yeah. Okay, Anas mentions that 20% can have without pyotic swelling as per literature. So ISA says the complication is well known. So optic neuritis can be seen in pumps without any other conditions or imaging phenotypes. Okay, we'll await the demyelination antibody, and we'll get back to you with a follow-up if it's positive or negative. Maybe also start collecting mumps cases, Dr. Lokesh, given the epidemic and the various manifestations of mumps.
Yeah, I think we have informed the AOCN. We have made an Excel sheet. I'm going to share maybe immediately after this. I'll share in this group and also on the AOCN for people to fill it up so that we can get out information as soon as possible. Yeah.
Right.
Thank you.
Thank you. Okay, next two sets of cases from Vizag, Dr. Prerna. Over to you.
Yeah, this boy is a 12-year-old boy who had onset of lower limb weakness since the last 4 months following an upper respiratory tract infection. Initially, the initial symptoms were noted 10 days after the febrile illness, where the child was falling quite frequently, and he was noted to have tremors, mainly intention tremors. This is the second born of a third-degree consanguineous couple, and there is a pre-existing speech delay, but motor development has been otherwise normal. So on examination, he had mild ataxia. Romberg's was positive. They were swaying to either side in tandem walking. And otherwise, there was no nystagmus. Power was okay. There was some amount of central hypotonia. Reflexes were quite brisk. There was no organomegaly. There was no neurocutaneous markers. So the child initially had symptoms somewhere around winter last year and was treated as ADEM outside based on the MRI reporting. CSF at that time was reported normal, but it was a hemorrhagic tap. So when he came to us, depending on the findings, we repeated the MRI with contrast in this child.
Okay, so I think the MRI was done like a week or so back. You have non-contrast T2s here, some multifocal abnormalities in the centrum semiovale, the frontal subcortical deep white matter, some degree of volume loss in the supratentorial brain. But the main findings are in the posterior fossa. You see patchy abnormalities of the brainstem over the right, the midbrain on the right side, and almost near symmetrical involvement of the bilateral cerebellar hemispheres. These hyperintense changes on the T280 sequences going down to the inferior cerebellar hemispheres, but predominantly involving the white matter structures of the cerebellum. Flare sequences again demonstrate similar imaging appearance. You can appreciate the cortical subcortical abnormalities better on the flare sequence in the supratentorial brain, periventricular abnormalities, but again the main findings are in the brainstem and the cerebellum on both sides. SWR sequences demonstrated areas of blooming on the left frontal lobe out there and some punctate areas in the bilateral cerebellar hemispheres. On the diffusion ADC, could not appreciate significant areas of restricted diffusion. Some mixed pattern, but not very significant for I call it as a too restricted diffusion out there. Spine non-contrast SAD sequence did not demonstrate any focal abnormality or myelopathy. Post-contrast, there is enhancement of the left frontal lobe lesion. These confluent fluffy areas of enhancement demonstrated in the bilateral cerebellar abnormalities, punctate nodular enhancement in the bilateral inferior cerebellar hemispheres. The cauda equina also demonstrated enhancement, the ventral and dorsal nerve roots. Spectroscopy was done, which demonstrated elevated choline peak, inverted lactate peak, reduced NA and creatine peaks. Based on the imaging findings, we thought of possibilities of HLH given the posterior fossa involvement and the pattern of contrast enhancement. Other possibilities were the other histiocytis related spectrum of disorders which can have similar imaging appearance, especially the posterior fossa abnormalities. A distant abnormality, a possibility of lymphoma, and then also to think of demyelination, given that the first scan had changes of ADAM, though we do not have the images, but the demyelination spectrum, MOGAD, is the most the one with the more extensive involvement. So these were differences kept, and I think the follow-up was done, Dr.
Yeah,
Prerna,
so
if you
his
can.
basic metabolic profile was normal, and also his workup for HLH was more or less normal. He doesn't have any osteolytic lesions of the bone. No organomegaly as well.
Bone
So
marrow?
basically, sorry, no organomegaly. So there's no
bone marrow.
hepatosplenomegaly.
Sorry, Prerna, bone marrow?
Sir, bone marrow was not done. Sir, actually, we had taken a hemato-oncology consultation. So they had said that because there are no other bone lesions, they hadn't suggested any bone marrow biopsy for this child, sir.
I think it is when the posterior fossa lesions are so prominent, it's worthwhile to go ahead and do the this one, because that's the first and second differential diagnosis with this kind of MRI.
Yes, sir.
Okay, so it's imperative.
Sir, and I was just wondering whether the acute phase reactants or whatever, whether they are modified, because he had taken 4 weeks of steroids prior.
Okay.
Prior to
Yeah, you have to
presentation
give a
with us.
gap and do it. Give a week's gap and then do it.
Sir, he took it in October. Like he took it during the first episode because he was treated as ADAM with 4 weeks of steroid.
Okay, right. So then that's fine. After that, if there is a gap of a long period, then you can still go ahead and do this one if you are not exposed to steroids again.
Okay, sir.
I don't know the follow-up. Yeah, please.
So as in, so I was just wondering, like normally with HLH, we would be seeing an elevation in these markers, isn't it, sir? Like, or should I just go ahead with the bone marrow irrespective of this?
This is some form of genetic HLH. We have had one child like this who initially responded partly to steroids, and then progressively she got admitted one day in the night with a raised ICP, and by next day morning she coded. And later on, she was found to have a genetic HLH.
Okay, sir.
So post this one, and then we counsel for next pregnancy. So this lesions in the posterior fossa sometimes are very significant, and they can be refractory if we give cyclo as well in between for that child, but we couldn't save her. Okay. So I think they are also from that part of the country, so somewhere in Andhra Pradesh, whether there is a gene defect which causes this kind of presentation.
Okay, so we've sent genetic this thing that is awaited. Meanwhile, if this child comes in again, probably we'll get the bone marrow done as well.
Absolutely, and we'll start more aggressive medication. Sure. Thank you. There are some questions for you, Nihaal.
Okay, so one is, can they say medication related? I'm not sure of the medication. So usually the toxicity changes demonstrate some diffusion abnormalities. So I'm not sure which medication can cause these imaging findings. Yeah, the toxic ones usually have diffusion changes too, I saw. And they're not patchy like what we have seen in our case. The next one is, can lymphoma be patchy? The intravascular lymphoma and the lymphomatoid granulomatosis can have patchy involvement. The variants of the lymphoma, that is the intravascular or the lymphomatoid granulomatosis variants, can have patchy involvement. So that is one, but they usually have a significant restricted diffusion, the lymphomas. In our case, it is not that significant. And then Dr. Sarba, comment from Dr. Sarbani that HLH may have only CNS HLH. So primary HLH, as Dr. Lokesh has mentioned.
Yeah. So, but we need to do bone marrow to just
bone marrow.
That whether it's primary into the brain or.
And abdominal ultrasound demonstrated mesenteric adenitis. Is that right, Dr. Prerna? Was the ultrasound
No, this is for the second case. Mesenteric adenitis is the second case. Yeah.
Sorry.
This one didn't have anything on the ultrasound. No osteolytic lesions on X-ray also.
Target lesion in MRI, is it present? The lesions, especially the posterior fossa, as you can see in the images out here, they are pretty characteristic or typical of HLH or the histiocytosis spectrum, especially the enhancement pattern, the heterogeneous involvement of the cerebellum. So HLH would be, at least on the imaging wise, a primary differential.
Okay.
Yeah. ISA says HLH is more probable in this case. Okay. All right. So Dr. Paedna, maybe you can get back to us with the genetics and the bone marrow.
Yeah. Sure.
Okay.
Thank you.
All right. The next case.
So this is a 13-month-old baby who had onset of focal seizures at 3 months of age. Initially, this was right focal, and in the subsequent presentations, the focus had shifted and it was more left focal since the last 3 episodes, affecting mainly the upper limb more than the lower limb, upper limb and face. There was history of neonatal seizures on day 3 of life, and this was treated as sepsis. So the duration of antibiotics was inadequate. They hadn't done any LP, so we don't know whether it was actually meningitis or not. Perinatal history was normal. However, this child has failure to thrive. He's only about 5 kilos at 1.5 years. Significant pallor is there. There's some central hypotonia and the reflexes are brisk. There's mild splenomegaly. Outside EEG was normal. There are no neurocutaneous markers. Otherwise, the child is not syndromic. MRI down outside suggested there were some old ischemic changes in the left parietal, and so it was treated as a complication of neonatal meningitis or meningoencephalitis. So because the child continued to have persistent seizures, and the EEG with us actually was suggestive of a right-sided focus. Mainly in the parieto-temporal area. So there were spike and wave discharges, and there was some amount of slowing in the right parieto-temporal region. So then we went ahead with the imaging in this case.
Okay, imaging flare sequences, you can appreciate the chronic change more in the superior aspect of the putamen rather than the parietal lobes. But again, you have some areas of gliosis in the internal capsule out here, the periventricular white matter, peritrigonal white matter. So chronic ischemic changes demonstrated here in the MCA territory. You can appreciate some edematous change in the basic frontal lobe along the Sylvian fissure out there, and no acute abnormalities on the diffusion weighted sequence. The SWA sequence demonstrated these almost conglomerated type tiny nodules, areas of blooming in the left temporal lobe, the anterior temporal lobe. Post contrast sequences demonstrated this area of peripheral enhancement out there in the basic frontal perisylvian region. The areas of possibly conglomerated lesions, but in the zoomed in picture, you can better appreciate these abnormalities in the Sylvian fissure and also in the anterior temporal lobe. Coronal sequence again, and yeah, you can the SAG and coronal sequences zoomed in pictures, you can appreciate the abnormality out there. On the angio, I think the distal branches of the MC are more displaced because of the lesion out here. But other than that, I cannot appreciate any other abnormalities on the contralateral side. Based on the imaging appearance, we thought of the possibility of tuberculosis. If you see the second image out here is pretty identical.
Dr.
to
Nihaal,
what
there was also one ring enhancing lesion, no? That was quite significant.
Yeah,
it was in the coronal section.
Lesion. So this is the ring enhanced lesion on the first image here.
Yeah.
And then you have the conglomerated lesions. So on the axil over here, you can appreciate on the first image, this enhancement, no restricted diffusion, I saw. Signal on T2 was dark. Sorry, I don't have the T2s. Yeah, so based on these findings, we thought of tuberculosis as the first imaging possibility. Then that also reminded me of a case, I think, which was presented by Kirti. Also, the patient was also from Vizag. More extensive involvement here, but you can see that the areas of involvement are relatively similar. We thought of TB as the first possibility, but the child on biopsy later turned out to be a fungal infection with multiple yeast cells. So that was a companion case for this imaging finding, and the imaging findings were pretty similar, especially the area of involvement and the signal changes and the contrast pattern. So fungal is a differential, I think, to be kept. So I think we have given these differentials, and I think Dr. Prerna had followed up with the chest X-ray ultrasound abdomen, which had mesenteric adenitis and mild sphenomegaly, and the sputum gene expert was negative.
Yeah, so currently, actually, we started this child on dual treatment, both with ATT as well as albendazole, because I wasn't sure whether this could be NCC as well.
I think you can stop that. Albendazole you can stop right now.
Okay, sir.
Yeah.
So should I go ahead for the biopsy or just ATT?
Wait for the response, I think. Wait it with steroids and wait for the response, and also probably immunodeficiency workup, such early age and severe failure to thrive.
Yes, sir.
So I think worthwhile to do it. Retroviral is negative, no?
Yes, sir. So, and this child is vaccinated also. There are no abnormal vaccine response or anything like that for this child.
I think they're trialing a new vaccine for TB, isn't it? In India only.
All right. Dr. Saroj says TB, ISA says TB or fungal or LCH. Screen the family for TB.
Yeah, both parents. So it's a nuclear family, just the parents and this child. There is no history of contact as such. Chest X-rays for both the parents are negative.
Okay. All right. I think we're going with TB as the first differential, Dr. Prerna. And
yeah. Okay.
Okay. Spectroscopy wasn't done. Okay, I think that concludes our new cases. We have 2 follow-up cases. The first is from Dr. Sarbani. If Dr. Sarbani is there. Dr. Sarbani, are you there? I can see you in the back.
Yes. Sorry.
Yeah.
So this is the case we had discussed.
Yeah.
And a couple of weeks back.
Yeah.
This girl admitted with repeated respiratory distress. So we had discussed at that time that it's probably intracellular cobalamin metabolism disorder. And Dr. Nihaal, if you could point out what were the radiological.
All right. So I think the gene has come pathogenic for cobalamin-related disorder. For the ones who did not see the case last time, just a brief intro. It was an 8-month-old with respiratory distress. Had a couple of pneumonias. On the background has microcephaly, developmental delay, hepatosphenomegaly, acidosis, and the imaging findings demonstrated some degree of cerebral volume loss and deep brain nuclear changes on the T2H sequences, some periventricular and centrum semiovale related abnormalities out there. The brainstem and the cerebellum also had some T2 hyperintense changes. I think the most important finding for us was the areas of diffusion changes on the globus pallidus, symmetrical areas on the globus pallidus, and also on the brainstem tracts. In the background of cerebral atrophy with abnormal white matter changes and these deep brain nuclear changes, I think one must think of cobalamin-related disorders as one of the differentials. Globus pallidus first, then the atrophy, and then the white matter myelination abnormalities. So these 3 changes should point towards the possibility of cobalamin-related disorders.
Dr.
The other
Nihaal,
difference.
Yes.
Sorry. Yeah.
Dr. Nihaal, I had an additional point to add here. The open sylvian fissure. Now, in the past also, the open sylvian fissure that we are seeing here, has been reported once in the past on a similar patient as glutaric, but this is seen even in cobalamin, this kind of an open.
So you will have to. It's more related to atrophy, but yeah, if the left side is more prominent than the right. The right side, I wouldn't call it open. The left, yeah, especially on the diffusion sequences you can see here. But when the child also has atrophy, you usually see these sylvian fissures widened. But I agree with you that the open sylvian fissures have not been described commonly with methylmalonic acidemias or cobalamin-related disorders. But when the child sorry.
No, go ahead, Nihaal.
No, usually when the child has atrophy, significant atrophy, the circle spaces are widened in general. So,
right.
Yeah. So what was the homocysteine in this child?
More than 75.
Yeah, no, don't accept the values of more than 75. Ask them to give exact value.
I agree that each lab has this giving it at beyond a particular level that they give me.
No, they can give titrations. We have a child with 260. We are trying to treat him. Today only we said them, you can't give more than 50. I want to know exact values. They will give it. They can do the titration because your management is based predominantly on how the homocysteine levels are in this child now.
I agree, but even with maximum efforts and maximum doses of betaine, it will not come below 50. So
injectable hydroxycobalamin?
Yes. See, in whatever patients till now I have treated of this disorder with hydroxycobalamin injectable with betaine, none of the patients that it has come down below 50, and that's why I had to once look into the literature, and I'm finding that it doesn't go below 50.
We have children where we have continued for 3 months almost every day in hydroxycobalamin. This child, this is cobalamin D deficiency, where you have normal other parameters on urine organic acids, and only you have atrophy like this along with epilepsy, refractory epilepsy, hair and skin changes. His homocysteine was high. So it took almost 3.5 years to walk with persistent chasing up the exact homocysteine levels. And now he's able to walk. He was severely impaired cerebrovisually. Sometimes 3 months every day intramuscular hydroxycobalamin. We train the parents to give it and then continue to give it. So we need to be very persistent with high dose hydroxycobalamin.
You think that it can be brought down to normal levels of 5 to 15?
Yes. It come down to 20, 30.
That's a revelation because I haven't been able to, but I think I could try with the daily hydroxycobalamin. I do give weekly. I don't give daily.
No, daily. They require daily.
Sure. Thank you so much.
Thank you, Dr. Sabani. I think Aisa has pointed out the main imaging findings on the chat, so people can have a look. Yeah, as mentioned, atrophy, subcortical white matter abnormalities, delayed myelination, hyperintensity in the basic ganglia, especially the globus pallidus. So our child had all the imaging findings which are typical for a cobalamin-related disorder. Thank you, Aisa.
Thank you.
Thank you, Dr. Savani. Our last follow-up case, this was discussed, I think, a couple of weeks back. Apurva, if you're there, or
yes, sir.
Anas, anyone? Yeah.
So this child, actually, we discussed in the last neuroradiology meet. This child had a history of fever with LRTI. In view of respiratory symptoms, child underwent like HFO, and then the first MRI brain was done, and so the child had.
I have the latest ones. So you want me to just go through the images first, or?
Sure, sir.
Okay, so December we had these main findings of confluent areas of cytotoxic edema in the subcortical cortical regions, more like an ALARD type pattern. And then on the follow-up, 10 days later, we had more progression in the deep brain nuclear structures, that is the basal ganglia, and the thalamus demonstrated these hyperintense changes. And the cerebellum and the brainstem also had some degree of edematous changes. Nothing on the SWI or there is a certain subdural hemorrhage along the left temporo-occipital region, but nothing in the parenchyma, and no hemorrhagic changes in the parenchyma. Post contrast, no parenchymal abnormality, some degree of dural enhancement, but other than that, we did not find any changes. In between, you want to just describe the clinical presentation, Apurva, from December to February?
So, sir, based on this, we did a brain biopsy, and in that we sent the biopsy to NIMHANS, where they said that the features were suggestive of demyelination. So we started the child on immunomodulation, and 2 doses of rituximab were given. After that, the child attained like CD19 levels were 0, and then it was almost a month. So we wanted, but there has been not much improvement in the clinical condition of the child. Dystonia is a little better, but child is not fixing, completely non-ambulatory, not tracking. Completely bedridden, developing spasticity. So after a month, then we decided to get a MRI brain repeat scan to see the findings.
Okay, so this is the one prior to the latest one. So in February 2024, we had these progressive changes in the bilateral cerebral hemispheres, predominantly the posterior hemispheres. You have some degree of mass effect on the right temporal-occipital region, going up to the corpus callosum, the lateral ventricles out there. The confluent changes in the bilateral hemispheres. This is non-contrast T1, and you can appreciate some degree of sulcal T1 hyperintensity, some cortical lamina necrosis, and on the SWA sequences, some microhemorrhagic foci in the bilateral hemispheres, predominantly in the right parieto-occipital lobes. Post-contrast, that time demonstrated the septomeningeal nodular enhancement in the bilateral parieto-occipital regions, the temporal lobes out there, especially on the right side. The Vino did not demonstrate significant findings. It's a normal variant on the left side, and child also had bilateral optic neuritis. The follow-up scan a month later, again, you can see the similar changes of the bilateral confluent abnormalities. The mass effect has reduced in comparison to the prior study on the corpus callosum and the ipsilateral ventricle, but there is progressive volume loss. The white matter changes are again confluent on both hemispheres. Now there is the appearance of cystic changes, especially in the right parietal lobe. And on the SAT sequences, you can appreciate the area of the extension of involvement of the right parietal region and some degree of volume loss out there. On the SWA sequences, again, microhemorrhagic foci along the parasagittal planes on both sides. Contrast on this scan demonstrated more of a gyral enhancement, a cortical enhancement. The leptomeningeal nodular enhancement is reduced in comparison to the prior study. No other areas of contrast uptake other than the parietal lobes on both sides and the temporal lobe on the right side. I think this was a biopsy. Is it right, Dr. Apurva?
Yes.
The one we had mentioned. So I think this was second opinion or sent again to Nihaal.
Yes, so we got the second opinion from Nimhans, where they said features of demyelination are suggested in the biopsy.
Okay. So still we don't know which form of demyelination. Is that right?
Yes, sir.
The autoimmune panels are negative.
Yes, sir. Demyelinating this MOG animo antibody, they are also negative.
Okay. We thought of vasculitis also as one of the possibilities again.
Yeah, they clearly said because fungal was one of the differentials.
Fungal, yes.
We clearly asked for it, and because the child was on amphotericin for a month or so, so that is one of the answer we wanted from them. They did the stains and then said it is not there. So we stopped antifungals, only immunomodulating cyclophosphamide the child is on. But the question for us is, with all the extensive investigations today available, we still have such children where so much of brain lesion pathology, and we don't get a definitive answer. So I don't know where we can actually, in spite of best of
genetics,
genetic we have not thought of because
I'm thinking again HLH possibility.
HLH, is it? Okay, sure. We'll get it done because we are immunomodulating. That can work for CNS HLH, but we'll get it done.
Any other suggestions in the chat, or
I think any suggestions on this case is welcome.
Yeah. Vanishing white matter, I saw the flare sequences are not typical of vanishing white matter. They're still hyperintense. Leukodystrophy, possible enhancement in leukodystrophy, atypical.
Any remote possibility of a neoplastic process that is causing?
Biopsy has not.
Biopsy has not picked up.
Yeah. Sure, we'll get the genetics done. Thank you.
Okay, I think genetics is a suggestion. So yeah.
Spectroscopy was done for this child, isn't it?
Spectroscopy was done, but it did not demonstrate any significant findings. MMDS from RC. Spectroscopy did not demonstrate anything, and the pathology also did not suggest anything. Anti-MOG was negative, I saw.
Thank you.
Okay, I think the last resort is genetics, so I think we have to evaluate for that part.
Sure, we'll do that.
All right.
Thank you, everyone.
Thank you very much, and yeah, We'll meet again in 2 weeks' time. You can submit your cases by 10th of April. If you want to join the WhatsApp group, you can message one of us or